Hi, everybody. This next set of talks is going to be on tachyarrhythmias and how to manage them. The first module is going to be more a review of pathophysiology. And I think by the end of this module, you should be able to describe the normal cardiac conduction system, and you should be able to explain how specific abnormalities in that conduction system can result in different types of tachyarrhythmias. Throughout, I'm going to be using this diagram to help explain different parts of the conduction system and how they go wrong. So to give you a bit of an orientation, this section here, these are the atria. This section down here, these are the ventricles. And all the purple lines that run throughout, those are supposed to represent the nerve fibers in the conduction system itself. More specifically in the conduction system, this spot here represents the sinoatrial node or the SA node. This is the atrioventricular node or the AV node. And the little bridge in between the atria and the ventricles is the bundle of His, which splits into the right bundle branch and the left bundle branch. And then all these other little fibers down at the bottom are their Purkinje fibers. Together, those fibers are all referred to as the His-Purkinje system, and I'll be using that terminology as we go through. So let's just start with a look at the normal conduction system. An impulse always starts at the sinus node, and that's what spreads throughout the atria to cause the atria to contract. If you were to look at an ECG, that section is represented by the P wave. The AV node receives that signal and gives it a little bit of a pause and kind of slows things down. So that pause is represented by the PR interval. The His-Purkinje system then receives the signal, sends it all the way throughout the ventricles, and that's what causes the ventricular contraction. And that's obviously represented by your QRS. And then when the ventricles just sort of depolarize or repolarize and go back to the way they were, that's what gives you your T wave. The slowing of the AV node is a key feature. This exists mostly to prevent the atria and the ventricles from contracting at the same time. So if you didn't have that, the system would just all flash at once. What you want to see is the atria contract, and then the ventricles contract after that, so that blood flows sort of in a forward direction. That slowing also exists to protect the ventricles from an excessively fast heart rate. So ventricles that beat really, really fast, like 150, 160 beats per minute, they don't have enough time in diastole to actually relax and expand and then fill up with blood. So that'll have consequences for your cardiac output. The His-Purkinje system, in contrast, has no sort of delay or slowing. It's the fastest conductive tissue in your heart. And this is also designed so that the ventricles will contract at the same time. So you want those things to contract really, really quick, really close together. And if you have some kind of abnormality in the His-Purkinje system, this is expressed on an ECG as a wide QRS. And the most common example of a conduction abnormality that gives you a wide QRS would be something like a bundle branch block. In a bundle branch block, you've got sort of a slowing of that His-Purkinje system somewhere along the way, which is resulting in one ventricle contracting quickly and one ventricle contracting slowly. And that's what you're seeing on the ECG. So you're seeing the fast ventricle in the R complex, and then the slightly slower ventricle in the R prime complex. So we'll talk about 6 different tachyarrhythmias: atrial fibrillation, atrial flutter, supraventricular tachycardia, SVT with pre-excitation, SVT with aberrancy, and ventricular tachycardia. So the first rhythm we'll talk about is the one that I think is most familiar to you, and that's atrial fibrillation. So in this rhythm, you've got multiple different foci in the atria that are just continuously depolarizing. Instead of the sinus node doing an organized beat, you've got a whole bunch of them that are just sort of bouncing all over the place. And the AV node just sort of picks up what it can and sometimes depolarizes the ventricles. The rhythm strip would look something like this. So the atria aren't really contracting anymore. They're just sort of spitting out little impulses without really mechanical movement. So there aren't really any P waves if you were to look at that baseline. You can see some sort of humps here and there, but there's nothing really that's organized. And because the AV node is just kind of picking up whatever it can, the AV node conducts totally at random. So the QRS is irregularly irregular. So if you were to look at the distance between these two QRSs and compare it to the distance between these two QRSs, and then compare that to this distance and that to this distance, you'd see that the distances are all completely different. So an irregularly irregular beat. Now, the atria, when they're fibrillating, will depolarize at 300 to 600 beats per minute. So this is super, super, super fast. But your heart doesn't just explode because the AV node is able to slow things down and keep it to that physiologic maximum that we talked about before. The second arrhythmia we'll talk about is the one that is most closely related to atrial fibrillation, and that's atrial flutter. This one's caused by a re-entrant circuit, and these are really common in tachyarrhythmias, so it's important that you have some understanding of what a re-entrant circuit is and how it works. A re-entrant circuit requires two pathways that start and end at the same location. And this happens all the time in tissue, usually because it's just navigating around something that's non-conductive. So that could be just an anatomic region where there's just normal endocardium that doesn't really have any good nerve fibers through it. Or it could be an area of old damage, like there's been a chunk of scar tissue in the endocardium that just doesn't work anymore. And the nerve fibers sort of regrow to kind of go around it so that they can reach their destination as they normally would. Sometimes that produces two different pathways. But generally speaking, that's not really a problem. The heart will function fine with that, unless one of those pathways is a whole lot slower than the other one. And you can get a slower pathway sometimes because those pathways are just there and native and you were born that way. And sometimes that's because one of those pathways gets damaged from something ischemic or a problem like that. In that circumstance, you can get one pathway that goes really fast and finishes just as that slower pathway is working its way all the way around. And if that fast pathway is all done by the time the slow pathway reaches its destination, it could actually go backwards through the fast pathway. And you could end up with this sort of cycling beat where things just go sort of around and around and around and around. And sometimes the AV node's getting triggered and sometimes it isn't. But these go really, really, really quick. And they produce an ECG that will sometimes look like this, at least in the case of a flutter. The ECG in a flutter often gives you this classic sawtooth pattern, or what people call a flutter wave instead of P waves. So if you look at that baseline, you'll see these sort of undulating humps. It looks almost like the serrated edge of a saw or a knife. It gives you that name. And this is another rhythm that beats really, really quickly. So it doesn't quite go as fast as atrial fibrillation, but the loop that gets created in a flutter beats around 300 beats per minute. And the reason you don't go that fast is because your AV node just doesn't conduct every beat. It's still sort of slowing things down. So you can see here it doesn't conduct, conducts, doesn't conduct, conducts. And it usually does that. It usually gives you every other beat that it's conducting. So classically, a flutter runs at 150 beats per minute, and it gives you 2-to-1 conduction. Now the picture I've shown you down here is actually 4-to-1 conduction. So if you look at that, you get a beat, a beat, a beat, and then a QRS on the fourth one. 1, 2, 3, QRS on the fourth. 1, 2, 3, QRS on the fourth. So this is 4-to-1 conduction. And at this speed, it's really easy to see that sawtooth pattern. But the classic picture is more like this, where you get 2-to-1. So you get a beat there, and then it conducts, another P wave, and it conducts, another P wave, and then it conducts, another P wave, and then it conducts. And that sawtooth pattern is sort of buried in there. Now the QRS in this circumstance is usually a very, very regular one. So if you were to measure the distance between those two lines, and these two lines, and these two lines, and these two lines, the distance is almost exactly the same, or it's very, very, very subtly irregular. So it's actually easy to confuse this one with something like sinus tach. But you just got to remember to look at that baseline. And if you kind of use your imagination a little bit, you can see that classic sawtooth pattern running through there. And this is a pattern recognition thing, but you should be very suspicious if you see a narrow complex that looks like sinus tach and it's running at exactly 150 beats per minute. Take a good look at that baseline and see if you can see the sawtooth pattern. Okay, so AFib and A-flutter are out of the way, so let's move on to supraventricular tachycardia, or SVT. I think this is where things start getting a little bit confusing for people. So first, just terminology. The term supraventricular just refers to an origin somewhere above the ventricles, right? Supra for superior and ventricular for ventricles, so superior to the ventricles. So strictly speaking, sinus tach, atrial fibrillation, A-flutter, those are all different types of SVT. But usually when we use the term SVT, we're referring to a rhythm that's coming from the atria And I just can't tell you exactly which one it is. So I know it's not sinus tach, it's not AFib, it's not a flutter, it's just something else, and it's coming from the atria. So when we say that this patient has an SVT, what we mean is that this patient has a type of SVT, and I just don't know exactly which one it is. SVT is also caused by a re-entrant circuit, and there are two major categories that I'm sure you learned about in med school and forgot everything about, but that's AV-NRT and AV-RT. Don't overthink this. AV-NRT means atrioventricular nodal re-entrant tachycardia, so it just means that the re-entrant loop is somewhere in or around the node, and that's what's causing the ventricles to depolarize. In contrast, AV-RT refers to an atrioventricular re-entrant tachycardia, which is just not nodal, and that's why they've taken out the N. Usually this means that there's an accessory pathway that's making the circuit. And so Wolff, Parkinson, White would be a classic example of that, where if you look right in that spot, there's this extra little bit of conductive tissue that connects the atria and the ventricles in some way that's not using the AV node. So here you'll see a flow that comes from the sinus node, goes down to the AV node, depolarizes the ventricles, but then uses that little accessory pathway to come back to the AV node. And so that's the re-entrant loop. Instead of this tiny little one around the AV node, it's this big loop that involves like half the heart. There are other accessory pathways that exist, so it doesn't have to be a little extra bit of tissue in that exact spot, but Wolff, Parkinson, White is the most well-known one, so that's the one that everybody talks about. The ECG that you get from SVT looks like this, and usually you won't be able to tell from looking at that if this is AV-RT or AV-NRT, or is there an accessory pathway, or which one, or whatever. So we just call these SVT. In this strip, the QRS is usually narrow, and it's usually quite regular, and the rate is usually pretty fast, running from 160 to 220 beats per minute. In that strip, it's really hard to see if there's any P waves because all you're seeing really is T waves and QRSs and T waves and QRSs. So P waves are typically not seen here. Now, sometimes if you have an accessory pathway, that'll give you a wide QRS instead. So you might end up with something that looks like this. And this brings us to the next topic, which is SVT with pre-excitation. Pre-excitation just means that there's an accessory pathway somewhere in that system. So as an example, if I put that Wolff, Parkinson, White extra little bit of conductive tissue back up, in a normal system, you'll see the sinus node depolarize the atria, but then that extra little pathway gets engaged and kind of reaches into the ventricle a little bit. That accessory pathway doesn't have the same kind of slowing mechanism that the AV node does, and so the ventricles get depolarized or excited a little bit earlier than usual. When the AV node engages and it reaches all the way around, it kind of runs into this impulse there, and that gives you sort of a funny looking ECG find, and that's that delta wave right there. And that can widen the QRS just a little bit, but that's something that you're only really going to see when the system is functioning in sinus rhythm. So when this system goes back into that circuit, like I showed you the first time, you're just going to see narrow complex tachy that just looks like any other SVT. You're not going to be able to pick up that delta wave. Now, you can get a wide QRS in an SVT with pre-excitation because the circuit can sometimes run backwards through that accessory pathway. So instead of going forward through the AV node, instead you're going in this direction, backwards through the His-Purkinje cells, and so now you've got a wide QRS that looks something like this. And there's a fancy word for this. So when you're running retrograde through the His-Purkinje system, they call it antidromic, and that's to contrast it with orthodromic, which is the usual way going forwards through the system. And I don't think you need to know what those terms mean. I think you should just see them and recognize them, because if you read around the topic, people talk about antidromic and orthodromic and that sort of stuff. So just so you've seen it once, it's there. The significance of this is that that wide complex that gets produced can sometimes look like V-tach, and sometimes they're hard to tell apart, especially if you were to go into atrial fibrillation. So if you go into AFib, both the AV node and the accessory pathway are going to be picking up some of these random foci that pop up. And you're going to get an ECG tracing that looks super, super, super bizarre with QRSs that are really irregular and in really different morphologies. And if you were to get a 12 lead of that rhythm strip, this is what you'd see, this completely uninterpretable mess. This is really confusing because all the QRSs just have completely different morphologies. So if you look up here, you're seeing some QRSs that are tall and short, even though they're in the same lead. You look over here, there's some that are wide and narrow, even though they're in the same lead. And there are some sections here that just like VTAC. So this is really bizarre and really difficult to interpret. And this happens because you're getting some of those impulses going through the AV node with one morphology, and then some of those impulses going through the accessory pathway with a completely different morphology. And this really confusing, bizarre ECG is almost pathognomonic for Wolff-Parkinson-White with AFib. So if you look at this ECG and you're like, these QRSs are all completely different and I have no idea what's going on, you should think Wolff-Parkinson-White and AFib because that's now pretty high up on the differential. Now, we said before that when you're in atrial fibrillation, your atria will depolarize at a rate of 300 to 600 beats per minute. So if you've got this accessory pathway that doesn't limit the speed, how come your heart doesn't just explode all of a sudden? Well, the AV node still exerts some control over the ventricular rate because in AFib, some of those impulses are going to be going sort of the usual direction. So it gives you sort of little breaks kind of here and there. But if you were to block the AV node, that could push all of those impulses down the accessory pathway. So instead of having things just go the usual route, if I turn off the AV node, everything goes down that. And there's now nothing slowing this down. There's nothing preventing a really fast rate from going through. And so your ventricular rate could theoretically top out at 300 or 600 beats per minute, trying to keep up with the atrial fibrillation. And obviously at that point, your ventricles are not going to do anything except fibrillate. So in Wolff-Parkinson-White with AFib, we do not use AV node blockers. So that's adenosine, beta blockers, calcium channel blockers, none of those. We don't touch those. And you should consider Wolff-Parkinson-White with atrial fibrillation when the QRS is wide and irregular. Now that I've said that, just to drive you crazy, there are other things that can produce a wide and irregular QRS as well that you need to be aware of. Which brings us to our next topic, which is SVT with aberrancy. Aberrancy just means that there's a wide QRS complex, and I just can't identify why it is. It's supposed to refer to aberrant conduction to the ventricles or just abnormal conduction to the ventricles. And a good example of aberrancy would be like a bundle branch block. So if I gave you this rhythm strip, you can see P waves and QRSs, P waves and QRSs, so it's in sinus. But that wide QRS has got a nice classic right bundle branch block pattern. So that's sinus rhythm with aberrancy, if you wanted to call it that. And this would be another example. So you've got a left bundle branch block pattern here. So again, you could call that sinus rhythm with aberrancy if you wanted to. Now here's the catch. What if this person with this left bundle branch block went into atrial fibrillation? Well, then you'd end up with a pattern that looked like that. And now you've got something that's wide and irregular. And that should trigger you to think, well, maybe this is Wolff-Parkinson-White. So this is another wide and irregular QRS complex, but there's no accessory pathway in here, right? This is just AFib with a left bundle branch block. So technically, AV node blockers are safe here. And if you wanted to rate control this person, that would be how you do it. But how do you know that this isn't Wolff-Parkinson-White with atrial fibrillation? Well, first of all, aberrancy is just way more common than an accessory pathway. You think about how many bundle branch blocks have you seen? Probably a ton. How many Wolff-Parkinson-White patients have you seen? Probably not a lot. The only way to really sort this out is either the patient knows that they have Wolff-Parkinson-White and they can tell you that, or you get an old ECG. So if you were to dig up something on the computer and you saw that this guy had this rhythm, 2 weeks ago, well, then you'd say, oh, okay, well, this here is just atrial fibrillation, but when it depolarizes, you just got one pathway that's really slow. This is just AFib with a left bundle. Now, we've mentioned VTAC a whole bunch of times, so we should talk about that next. Ventricular tachycardia occurs when you get a re-entrant circuit that develops around some non-conductive tissue somewhere in the ventricle. And this is almost always damaged tissue. So this is an ischemic area that's now scarred over. It's almost always a characteristic of a sick ventricle. You get backwards flow through the His-Purkinje system, so that gives you a wide QRS again. And the rate ranges from something like 120 to 300 beats per minute. The rhythm strip classically looks like this. You get these big sort of tooth-like spikes going up and down. But the QRS can be regular or irregular, so something like this is also very possible. And it's hard to appreciate because this is going so fast, but if you look at the point between those two QRSs, and you compare it to that point, and you compare it to that point, you can see that the space between the QRSs is irregular, so this is definitely an irregular beat. You might even see something like this, and you recognize this, of course, from ACLS as torsade de pointe, and that's just a subtype of VTAC which is associated with having a long QT at baseline. We worry about VTAC because we know that this can rapidly degenerate into ventricular fibrillation. Remember, this is almost always a sick ventricle. There's been some ischemic damage and there's some scar, and that's how you got that re-entrant circuit to begin with. So if you take an already sick ventricle and you just make it beat really, really, really fast, it's only a matter of time before it just collapses into VFib. This can also just be a pulseless rhythm all on its own, so these patients are usually quite unstable. Now, every so often, the patient does present stable, and in those circumstances, it can be really difficult to distinguish VTAC from SVT with a wide complex. If I put up something like that on the monitor, that's pretty clearly VTAC, but if that patient looks pretty good, and if instead they had a rhythm that looked kind of like that, more irregular and kind of an uglier rhythm, I think it would be hard to tell that that's not VTAC. So in reality, this is just AFib with a left bundle branch block. It's a much more benign rhythm. So the rule of thumb here is that if there's any doubt, you should just assume that that fast, wide complex you're looking at is VTAC, because that's going to be the most concerning finding. It's going to be the most unstable one, and it's not one that you're really going to want to sit on and analyze that ECG for too long without doing something about it. All right, that's it. So let's summarize what we talked about so far. Classically, we put these into 4 big boxes to help keep them straight. So the first one is the narrow regular complexes. The second is the narrow irregular complexes. The third is the wide and regular complexes. And then the fourth is the wide and irregular complexes. In the narrow and regular box, you're going to have SVT and a flutter. And in the narrow and irregular box, you're pretty much just going to have AFib. You could have a flutter as well, but it's kind of a who cares conclusion at that point because you're going to treat it the same way. In the wide and regular box, things get a little bit more complicated. So you're going to have VTAC as a big concern, but you could also just be looking at SVT with aberrancy or SVT with pre-excitation. And the wide irregular box isn't really a whole lot different. You're going to start being concerned about VTAC, but that could just be AFib with aberrancy, or it could be AFib with pre-excitation. Now you could simplify this even further. You could just say, I don't like those terms, just scratch them out, and instead just say, well, aberrancy is a bundle branch block and pre-excitation is Wolff-Parkinson-White. I think that's an oversimplification, but I think that's how most of us think about it anyway, because those are the 2 most common syndromes, and they're going to be the only syndromes that come up that you're actually going to be able to put a name to. The rules of thumb that you should keep in mind: narrow is always going to be an atrial rhythm. That's always something coming from the top half of the heart. And if it's irregular, that's usually going to be an atrial fibrillation. When you get into wide complexes, that's when things start getting stressful because there's the potential for VTAC or some sort of ventricular rhythm, but it could also just be aberrancy, or it could be this Wolff-Parkinson-White thing. And the way you sort that out is usually finding an old ECG. The patient might be able to tell you if they have something like Wolff-Parkinson-White, but that almost never happens. And again, if there's ever any doubt about where this wide complex might be coming from, you should assume that this is ventricular tachycardia. Okay, next talk we're going to go over some of the medications and ways that you would manage some of these arrhythmias, so I hope you'll tune in for that.